Thank you, Professor Iqbal, for the kind introduction. It has really been an honor to organize this Aortic Symposium in order to, it's basically to provide the audience with an input of what kind of diseases that we have here and what kind of management are we doing. I think the idea for this Aortic Symposium came because there is a kind of a myth that exists that vascular disease and especially aortic disease doesn't exist in Pakistan. Since we've been working here and we've established a vascular department, there is a huge variety of different aortic disease that present to us. I'm sure if there are people who are joining from some other parts of the world, having worked in UK, I know that I have not seen the kind of variety that I come across here in Pakistan that didn't exist in UK. So basically, my talk is going to be about presentation of aortic disease, and it is a review of cases. So these are all the cases that have presented to us here. I am not going to go into details of the management because that is an entirely different topic. But what I want to show is the different variety of cases that present to us. Some of these cases I will just tell briefly about the management that has been done. Some of these cases will be presented in the next talks by Dr. Jamshed and Dr. Zahid about the management as well. So just as a disclaimer, I'm a proctor for Medtronic for endovascular aortic stent graft, but don't have any commercial interest to disclose. Presentation of aortic pathology. So essentially, we know that aortic pathology, the commonest aortic pathology that presents is atherosclerosis. And the commonest presentation in the form of peripheral vascular disease is occlusive disease. Occlusive disease, peripheral vascular disease is very common in Pakistan, associated with high levels of diabetics, high numbers of diabetics, and quite significant amount of people who smoke. But the presence of aortic aneurysm, there is no paucity of that as well. We do come across patients who have got, who present with simple standard aortic aneurysms, and then those who present with complex aortic aneurysms, including mycotic and pseudoaneurysms as well. Aortic dissection is quite common as well. And interestingly, only today, as Professor Iqbal has mentioned, there is a type A dissection being operated in theater right now. And we have received in ER a patient who's got a I wouldn't say type B because it's just abdominal aortic dissection. She's a patient who's come from Afghanistan, and she's got an aortic dissection starting at the level of the celiac, going down into the iliacs. So this disease, again, does exist here. It's a matter of presentation and management. Traumatic aortic transection, again, something which we have come across quite frequently. And this is a problem which only you will find if you are looking for it. Otherwise, it's very easy to miss and is associated with very high mortality. And then there are the problems like coarcation of aorta, vasculitis, congenital anomalies. So I'll show you examples of these as well who are presented to us. So as I've said, we will be going through cases. I'll be showing a good number of CT scans to discuss these, to show you the presentation and briefly about how these patients were managed. To begin with, aortic occlusive disease, as I've said, peripheral vascular disease is very common. It is associated with atherosclerosis, and people over the age of 40 can have atherosclerosis developing in their blood vessels, which increases with age. The prevalence of asymptomatic peripheral artery disease is reported up to 11%, present in both men and women, and is higher in low and middle income countries compared to the high income countries. And ethnicity also has a role to play with it. Aorto-Iliac Occlusive disease, more likely to be in smokers, and is associated with higher morbidity and mortality as compared to the general population. Natural history of peripheral vascular disease or Aorto-Iliac Occlusive disease is that of claudication going on to rest pain and tissue loss. Frequently, these patients present late to us, and there are multiple factors for that. The most common is anxiety, because these patients are afraid that they will end up losing a limb. And yes, that is a true worry that these patients have. But unfortunately, when they present late, then that risk has actually increased. Patients also come to us after having gone to general surgeons, orthopedic surgeons, neurosurgeons, mainly because it's leg pain. And unfortunately, peripheral vascular disease is something which is quite at the bottom of the differential diagnosis for many doctors. It is common, but not many doctors think about it. And hence, sometimes I've even come across patients who've had unrelated surgery done, thinking that this might be a patient who's having something like sciatica or disc prolapse, and surgery was done for that. And actually, the underlying problem was that of peripheral vascular disease. So, first case, a 63-year-old male, smoker, hypertensive, diabetic, and had worsening claudication for a few months, and now presents with left foot rest pain and gangrenous toes. This is the CT scan. You can see there's disease in the aorta in the thoracic segment. When we come into the abdominal segment, the visceral part of the aorta is fine, and then there is complete occlusion of abdominal aorta going into the common iliacs. Going down the external iliacs, you can see come back, and then the femorals are fine. And this patient then has a reasonable runoff going into the lower limb vessels. So this patient is a typical case of significant peripheral vascular disease, as presented in a condition that needs something to be done for revascularization. He was assessed for fitness for open surgery, and an open aorta biiliac graft was done with successful result. Another example of similar disease, a 57-year-old female, diabetic, hypertensive, right foot ulcer, and rest pain. And if you look at the CT scan, the thoracic segment of the aorta has got a small mural thrombus in it with a free floating edge, which is again a risk for embolization. But in her case, there is complete infrarenal aortic occlusion going into the iliacs all the way down into the femoral arteries. So again, it's a very similar case, and this patient also had successful open surgery done. This is quite, I think, for me, one of my quite surgeries which I really like, because for vascular surgeons operating on the blood vessels, generally you are doing it so routinely that the thrill is not there that much while you're operating on the lower limb or the upper limb vessels. But doing this aortic occlusive disease, where the occlusion lies right at the level of the renals, in that case, that's a really interesting part when you put the clamp on and you haven't clamped the vessel, and you open the aorta in order to remove the plaque and then put the clamp on. So that is the really thrilling part of the surgery. This is another patient. Now, this is a patient with stenotic disease. I know now there is quite a lot of advancement from stenotic disease point of view in the form of CRAP, that there is endovascular opening of these very severe aorto-iliac disease with multiple stents included in the aorta and iliac vessels. Unfortunately, that is something which is quite expensive, and we're not doing that here very often, or in fact, we haven't done any case of complete aortic occlusion for an aortic stent, but we have done a good number of iliac stent patients. But this is a patient who, if you look at, is a diabetic, smoker, and he's got infrarenal aortic disease with stenosis in the aorta and stenosis going into the iliacs, more in the left. He's also got occlusion of his right common femoral artery, and then a stenotic disease with a short segment occlusion in his superficial femoral artery. So this patient, we had a long discussion about it, that should we manage it with endovascular method, or should we go for open repair? He was investigated for his fitness, and in fitness his investigations were very good. So therefore, decision was made to go for open repair in order to give us a better long-term result. So this patient had an endarterectomy of aorta and his origin of the common iliacs more in the left than the right. And then he had reconstruction of the iliac bifurcation and a bovine patch, pericardial patch repair of his aorto-iliac endarterectomy segment. Simultaneously, we also did right common femoral artery endarterectomy and bovine patch repair. His problem was that of left first toe gangrene and rest pain, which improved after the surgery, but his symptoms didn't completely settle. So after about 6 to 8 weeks, he's recently had angioplasty, successful angioplasty of his left superficial femoral artery as well. This is an example of an Aorto-Iliac stenotic disease, a 64-year-old male smoker with history of hypertension. He had bilateral short distance claudication and right foot small non-healing ulcer. This is his angiogram done at the time of therapeutic procedure. And as you can see that there is a tight stenosis of left common iliac origin. He had calcified disease going at the aortic bifurcation going into the common iliac, and then occlusion of his right common and external iliac artery. He had a bilateral kissing stents in order to tackle with the iliac disease, the common iliac disease, and the bifurcation disease, and then the stent is coming into the right external iliac, and then angioplasty was done for the rest of the external iliac with successful revascularization. Acute aorto-iliac occlusion, that does present, and we've seen a fair share of those patients as well, usually embolic in nature. And we have seen a significant number of cases since COVID. As we know that COVID is associated with increased incidence of procoagulant condition. It's a procoagulant condition, and therefore patients are presented with thrombosis of different parts of the blood of the body, blood vessels, arteries, veins. So we have seen patients presenting with peripheral vascular occlusion and also aorto-iliac occlusion. So this is an example of a 40-year-old male who was recovering from COVID. The symptoms were about day 17, day 18 when he developed left leg ischemia. His CT scan showed there to be embolus sitting at the aortic bifurcation going into both the iliacs and also into the left leg going down into the popliteal. So he had bilateral femoral embolectomy done and then was managed successfully with anticoagulation and has done well. Next, we move on to aortic aneurysms. As we know, aneurysms can be fusiform or saccular, and then we can see pseudoaneurysms or aneurysms associated with dissection. It's not an uncommon condition. Screening studies have shown 4 to 8% prevalence with an annual incidence of new diagnoses in 0.4 to 0.67% in Western population. Which is about 2.5 to 6.5 aneurysms per 1,000 person year. This condition is more common in men than women, with a prevalence of about 1.3 to 8.9% in men and only 1 to 2% in women. Thoracic aortic aneurysms are less common, with an incidence of 5 to 10 per 100,000 person years. These can present again in many different ways. The first case is that of a saccular descending thoracic aneurysm in a 58-year-old male with history of hypertension. He was investigated for symptoms of shortness of breath, no history of trauma or fever. And in this imaging, you can see that there's a small blip after the left subclavian artery in his thoracic aorta. Better imaging can be seen in this, in which, as we come down to the thoracic segment, we can see that in the arch, just after the subclavian, there is a saccular thoracic aneurysm. So this patient is being planned for surgical, for intervention. And in fact, we were just discussing this case a little while ago. He's been assessed. There is a very little landing zone in this patient between the aneurysm and the arch vessels. So the repair can be a complex repair. If it's endovascular, it may need revascularization of the carotids and subclavian, or if it's an open repair, then it will be with on-pump bypass and then replacement of the aortic arch and a small segment of descending thoracic aorta. Moving on to thoraco-abdominal aortic aneurysms, we know that these can present in many different ways. It's quite a complex classification of these aneurysms involving different segments of the descending thoracic aorta, abdominal aorta going down to the iliac bifurcation. The most difficult part in this is involvement of the visceral segment of the abdominal aorta. So this case is that of a 69-year-old male with an incidental finding of thoracoabdominal aortic aneurysm. While we were investigating him for fitness, we identified there was significant coronary artery disease, and therefore, as part of planning, initially a coronary artery bypass graft was done, from which this patient has recovered, and the plan is now for an open repair. So the CT scan basically shows that the aorta becomes diseased below the left subclavian. The initial part of the aorta is not very enlarged, but as we go down towards the thoracoabdominal segment, we will start seeing aneurysmal dilatation to be increasing in size with a significantly large, more than 6 centimeter aneurysm of the thoracoabdominal segment, from which the celiac is arising. The origin of the celiac is diseased, the SMA is arising, and then just at the level of the renals, the aorta becomes normal in size. So this patient, the plan is to go for an open repair. Thoracoabdominal branch grafts or fenestrated grafts, those are options as well, but the cost is also affected in these in management of these patients. So next patient is that of a juxta renal aortic aneurysm, an elderly male who was diagnosed to have an aortic aneurysm for a few years when they presented to us. And he had history of small cell carcinoma of lung, which was managed successfully, and he had recovered from it. But from an aortic aneurysm point of view, he did not want an open surgery. So this was our first complex aneurysm repair, which will be discussed further by Dr. Jamshed in his talk. This is the CT scan of the same gentleman. So the thoracic segment of the aorta, slightly diseased, but not aneurysmal. As we come into the abdominal part, we can see the visceral vessels coming, and just below the level of the renals, there is a conical neck for which standard endovascular stent was not possible. The aneurysm then extended into the common iliacs with the normal vessels below. Another patient with large aortobiliac aneurysm, 76-year-old male, diabetic, hypertensive, and he also had a popliteal artery aneurysm along with a bilateral aorto-iliac aneurysm. This patient had multiple consultations with different centers. I think he went to every known and maybe unknown vascular surgeon in Pakistan. And he also had consultations abroad. I'm sure they told me they had consultations in Singapore, maybe in UK as well. So it's an infrarenal aneurysm with an angulated neck, very large, more than 7 centimeter abdominal, and then bilateral, large, more than 5 centimeter iliac segments, iliac aneurysms. So again, this patient, we did manage a successful endovascular treatment, and he's had more than 1.5 years of follow-up with us. A standard infrarenal aortic aneurysm, I thought I'll show a simple one as well. So 80-year-old male, large fusiform partially thrombosed infrarenal abdominal aortic aneurysm. He's had left aortic angioplasty done in the past as well. So this is quite a standard aneurysm with a good infrarenal neck, about a 6 centimeter infrarenal aortic aneurysm, and open or endovascular repair. Both are suitable depending on the fitness and patient choice. Ruptured aneurysm. So we do come across ruptured aortic aneurysm as well, not very frequently. And as we know, there's a definite relationship between the volume and the outcomes. So ruptured aortic aneurysm presenting here, usually late. Unfortunately, I can't say that the outcomes here are excellent, but yes, we have managed them successfully as well. So this is a youngish 67-year-old male. This contrast, this scan was done in the emergency. We didn't have contrast because of the condition of the patient. And this was quite a complex aneurysm starting just below the level of the celiac with leak expected to be just at the level of the renals. So the condition of the patient and looking at the scan, masterly inactivity was decided for this patient. Another patient with ruptured aneurysm, 73-year-old male, presented with very typical history of abdominal pain and collapse with a large pulsatile mass in the left lumbar region. And his CT scan confirmed there to be presence of leaking aneurysm. And this patient, we did manage to take him to theater, and he did manage to survive this open repair of a leaking aneurysm. As far as endovascular repair for these patients is concerned, we are not geared up for that, as we don't have a stock of endovascular stent grafts available with us to try and manage these patients. So here we are with the CT scan. Those are the renals, and below the renals, there is a neck. So in this case, if it might have been possible to do an endovascular repair, but you can see there to be a large aneurysm with significant amount of thrombus in the retroperitoneal space. Mycotic and pseudoaneurysms. This is an example of a patient who was quite 76-year-old, but a very active lifestyle, and he had significant peripheral vascular disease with not lifestyle limiting claudication. And basically, his CT scan showed there to be presence of penetrating ulcers in the infrarenal segment, and one of these ulcers had ruptured, causing formation of a pseudoaneurysm in the infrarenal abdominal aorta. And again, he was managed with an open aortobiliac graft. Mycotic aneurysm is also something which we come across. So this is a 60-year-old female, abdominal pain and fever, and she had this 3.5-4 centimeter infrarenal aortic aneurysm, which on serial imaging was rapidly increasing in size, and therefore had open repair with a Dacron graft. Thoracic aorta, this patient had history of pancreatic resection a few years ago. He presented with chest pain and hemoptysis, and his CT showed this pseudoaneurysm present in the descending thoracic aorta, successfully managed with endovascular repair. And I think Dr. Zahid might be presenting this case in his talk as well. Next, we move on to aortic dissection. As I've said, it's not an uncommon condition, and it is something which present to us. There's a patient in ER right now who's been shifted from Afghanistan. It's chronic dissection of the abdominal aorta, so we're not planning to do anything immediately for this patient. And there's a type A dissection going on, surgery going on in theater, for which if we have time and we find the link, then we will talk to Dr. Haris there as well. So this is 5 to 30 cases per million people per year, more common in males. And the most important thing is identification of acute or chronic. 2 weeks is the time when we start calling it chronic dissection. And as we can see that there is Acute is associated with a higher morbidity and mortality as compared to chronic dissection. Type A dissection or type B dissection, the main difference is involvement of the ascending aorta or arch, or only the descending aorta. So left subclavian artery is the point which differentiates between acute or chronic dissection. Higher mortality in acute dissection and lower mortality in chronic dissection. This is a case of dissection which was starting just at the level of the left carotid artery, going down into the abdominal segment. This patient presented with severe chest pain and back pain, a young patient, history of hypertension only. And this is a patient which we have managed successfully with open thoracoabdominal repair of this dissection. And the patient went home about 3 weeks ago. Type B dissection with intramural hematoma, again, a young patient, hypertension. He presented to ER with severe chest pain. And there were some ECG changes as well. So initially, cardiologists were involved, and the patient, considering it to be an acute coronary event, the patient was being taken to the cardiology lab, to the cath lab, when he presented. Initially a CT scan was done as well because things were not very clear. So when he was being wheeled to cath lab at that time, the CT scan was reviewed and diagnosis of a type B dissection with an intramural hematoma was made. There were two flaps that could be seen. The initial dissection flap seemed to be slightly distal to the left subclavian artery. And then there was another point which could be seen above the level of the celiac, and the intramural hematoma extended till that point. Because the patient symptoms were settling with conservative management, therefore we opted to go for serial imaging and to observe the dissection. And basically what we have observed over the serial imaging is that the intramural hematoma in this patient has settled. The proximal dissection flap at the level of just below the subclavian is completely gone. So if we look at the imaging now, just below the subclavian, there was a flap and intramural hematoma, but now we can see the aorta to be completely normal over there, with no intramural hematoma, no flap, and no aneurysmal dilatation. However, as we come down, the point which was the distal flap point, which we initially kind of ignored, is the one which is now causing problem, and we can start seeing now there to be an aneurysmal dilatation developing, which is coming into the picture just now. So this aneurysmal dilatation is progressively increased in size and is coming almost to the level of the celiac origin. So we've had multiple discussions with this patient. We have kind of discussing about endovascular stent for this patient. The aneurysm is very close to the celiac, so that is that option available or not? It's only something which we'll see when the patient agrees to have the treatment done, and then we can do a final planning. So chronic aortic dissection, I think we see more patients with chronic aortic dissection coming to us. And in that case, the main thing is that is there any risk of complication associated with chronic type B dissection? This is a 60-year-old male patient who's been under surveillance now for almost 2 years. When they presented about 1.5 years after his initial event of chronic type B dissection, which was managed in another hospital. He is hypertensive, hypertension is being managed. He's got aneurysmal dilatation of his aorta. As you can see, the dissection starts just at the level of the subclavian and goes all the way down into the abdominal aorta, into the iliac. The right renal comes from the false lumen. All the rest of the visceral vessels are coming from the true lumen. And I think at some time, this patient is going to require some intervention as well. Aortic transection is something which is quite common, and the most important thing is you will only come across these patients if you are keeping an eye out for them. If in our hospital, where we don't take trauma regularly, we have done a reasonable number of cases with aortic transection, then this means that the numbers presenting to hospitals taking trauma must be very high. So examples of aortic transection, this is a patient who presented after a collision, an RTA, and this is a grade 2 transection just below the level of subclavian with an intimal flap and a small thrombus extending into the aorta. This is a patient, another patient who had a fall from first floor, and in this patient, it's a grade 3 transection formation of the pseudoaneurysm, as you can see in this CT scan. Here you can see the transection with the pseudoaneurysm formation just below the level of the subclavian. So these patients, if they are picked up early, then endovascular management has completely changed the treatment with very low risks and very good outcome. Coarcation of aorta, uncommon to be presenting in adults, but we have recently had a couple of patients presenting with uncontrolled hypertension, symptoms of lower limb claudication, and the transection was confirmed, and they've been successfully managed endovascularly, which Dr. Zahid may be presenting in his talk as well. A couple of cases of some odd presentations, and then I'll finish my talk. So TAKAYASU arteritis, we know, is a granulomatous inflammation of aorta, and it can present with stenotic and with aneurysmal disease. It affects women more than men, and these patients may be completely asymptomatic, but manifestations can be systemic, cardiac, vascular, neurological, and dermatological. So this patient has been with me, a 36-year-old male, has been with me for almost 2.5, 3 years now. He had the initial episode of TAKAYASU was almost about 7 to 8 years ago. And now what he has is multifocal disease. He's got occlusion of his right carotid artery. He's got then disease in his thoracic aorta with some aneurysmal segments. And the initial presentation to me was with this Saccular type of infrarenal aortic aneurysm just below, it was juxta renal, just starting at the level of the renals. And there was a lot of discussion about how to treat this patient. I discussed it with my colleagues in UK as well, and there was a very varied kind of suggestions. Should not be done anything, or just treat it endovascularly. And basically, after a lot of discussion and after fitness assessments, I managed his infrarenal aortic disease with open surgery. That was almost about 2 years ago. And the thoracic disease is something which we are keeping an eye on. And he's on long-term management for TAKAYASU's arteritis. This is another patient, again, a young female patient. She's also got multiple vessels involved. Thrombosis of his right subclavian artery and axillary artery, left subclavian has got some stenosis. And the disease that she presented to me with was mainly that of aortic stenosis, almost a completely occluded aorta just below the renals. And the level of the renals is also very stenosed. Her kidney function was fine, and the decision at that time was to monitor this. This is now, the scan is before we started with this COVID. So it is now more than 1.5 years ago, and she hasn't come back to me yet for follow-up. The last patient is an anatomical variant. This patient is a known case of chronic kidney disease, and after an insertion of a neckline for dialysis, the chest X-ray was done, which showed there to be an odd position of the neckline, and the nephrologist was very worried that we have damaged one of the main vessels. But on imaging, what we found was that this is an aberrant origin of his right subclavian artery coming at the level from the descending thoracic aorta at the level of the left subclavian artery with aneurysmal dilatation. So again, a complex disease to manage. So these are the different cases, and you can see that there is a huge variety of aortic bases that present to us. Management of these patients is a challenge, but fortunately, we have developed a team including vascular surgeons, intervention radiologists, and cardiothoracic surgeon, where we have got a wide variety of experience, and we are trying our best to provide as much different varieties of management options to the patient as can be offered. So now I'll pass over to Dr. Jamshed. He's an intervention radiologist, and he will be giving his talk on endovascular management of abdominal aortic disease.